Okay, hi everyone. Thanks to AHA and Sue for inviting me, and thanks for staying late. The downside of I'm honored, honestly, to be able to speak after all these amazing speakers, but the downside is the bar is really high right now, and probably most of the material is going to be repeated, so I apologize for that. I'm going to move forward. I have no disclosure, no financial disclosure, at least. So they told me don't talk about any devices or advertise for anything, but they didn't mention I cannot advertise for where I work. So I'm going to talk about, this is a repeated slide too from Dr. Laura McGuire, but I wanted to talk about UW a little bit. It's a comprehensive stroke center, proudly recognized as the first comprehensive stroke center in Wisconsin. No offense to our colleagues in Milwaukee. In 2024, we treated over 700 stroke patients, and we responded to approximately 1,200 actually stroke codes. So our stroke program is built around two dedicated teams. One is taking care of patients with inpatient care, and the other one is mainly consult team and stroke codes. We do have, the team is run by neurology resident, APPs, and faculty, both team. We have around 21% of the patients come from outside of the hospital, outside of the region, primarily from Wisconsin and Illinois, and sometimes UP. As north as UP. So we do have a 24-hour dedicated neurosurgery team to our hemorrhagic stroke patients. And about 18% of our patients are hemorrhagic stroke. We do have 24/7 access to our APPs that are overnight taking care of our hemorrhagic patients. We do have 18-bed ICU, a 12-bed IMC care, and 25 general care bed for taking care of the neuroscience patients, all covered by neuroscience-trained nurses. And we recently started, not so recent, 2 years of a comprehensive hemorrhagic stroke clinic that only takes care of the hemorrhagic patients. And we do have an amazing team. Shout out to the table there and some over there. We do have a big, amazing team of stroke program manager, director, coordinator, and team taking care of the data and quality improvement projects. So the learning objective, understanding the prognostic factors and outcomes, identifying the goals of care, and also the post-acute care and rehabilitation. Rehabilitation strategies to maximize the recovery of the patients, long-term follow-up and support of the patient and their families, which is very important, and interdisciplinary collaboration for optimal patient outcome. So recovery and rehab after ICH, it's usually after the post-acute care has passed, what comes next and how does recovery looks like and how to support patient is a long and winding road for patients and their family, and is often very underrepresented in stroke discussion, but it's absolutely vital for long-term recovery and outcome. You've already seen some of the hemorrhagic stroke images. I'm just going to point to some of them that from the recovery standpoint, I'm definitely not going to take care of this patient in the clinic, or maybe this one, but most of them, like if you look at the upper and right image, that's a lobar hemorrhage, but if you, based on all the discussion that you've heard since this morning, that's after a CTA is necessary for that patient and you see a ruptured aneurysm. The lower one is a lobar temporal parietal lobe hemorrhage. That usually, if I want to put my money on a diagnosis, would be a CAA. This image up here, you see a little bit of clot here. If it's a little bit hard to see, but that's a venous sinus thrombosis, and there is a hemorrhage on that area, which is a venous infarct. And the next one is an IPH with IVH expansion. So why it's important to we need to have some tools to figure out which one we should start the rehab early enough in the hospital. We need to learn some tools. I don't know why it's not moving forward. Okay, great. So ICH score, you heard about this 5 times today. It has some components. I'm not advertising for anyone. This study was done in 2001, published in 2001, I believe, and Dr. Hemphill was my mentor, which I'm very proud of. So it shows all the ICH score, that the way that is calculated depends on the age, the volume, the location of the hemorrhage, and we saw that the ICH score of 5 is usually like close to 97% mortality and 6 is death. So the other tools that, you don't need to memorize ICH score and calculating it. There are tools you can use online and Google it. Is that allowed to say Google it? But you can use these on your phone and calculate the mortality rate. And this is helpful for having a discussion with the family and their goals and see what they really want for their patient and what they discuss. And Hahn-Hess is very famous for subarachnoid hemorrhage. It's a similar thing. The number, when the grade goes higher, the mortality rate goes higher as well. And this is the same from the MD calculation, and you can calculate that easily. So where and when the rehab starts. This is when we use these tools and we give a pause, as we heard this morning, to make sure the patient we are not gonna call it the first day the patient comes in. The first day is usually make sure patient is stable. There are these studies that shows you can start the recovery at a comprehensive stroke center. Usually it's approached as usually it starts to achieve an early supported discharge in patients with mild to moderate ICH, which means the MRS less than 3 or less than 3, within 24 to 48 hours, as early as that. And to achieve that, you really need a village for that. But the key is to I actually saw a nice poster out there about early supported discharge out there. Check it out on your way out. So the key of the early supported discharge is continuity of care and intense rehabilitation. This helps patients to get back home early within 3 months and get more care in the community care centers. But you need neurology, neurosurgery, physiatry, rehab doctors, social work, case manager, neurophysiology, and nurses. So you need a whole team to make this happen. So, but there was a trial that shows if you start doing this very early rehab, you actually can cause harm to these patients. So the first 24 hours, try not to touch the patients and just keep them in bed and make the head elevated and all those acute care that you heard about so far. So what we usually focus on outpatient setting is there are 4 components that I'm going to go through. The first one is motor function. Actually, 50% of patients, they show up with hemiparesis after having an ICH, which is a big number. The spasticity, which is 40%. And after spasticity, when they have it for a long time, they end up with frozen shoulder, which no one pays attention to, and they start having shoulder problem. And I recently had a year ago, had a shoulder problem. And since then, all of my notes, they have frozen shoulder section in it, and I pay attention to that, and I send them to orthopedic surgeon if I find one of those to take care of at least the pain. Dysphagia is 50 to 70%, which causes aspiration pneumonia. That's important to catch it early enough. And fall and mobility impairment, those are the main component that we see as the motor function as outpatient, and are also early early rehab in the hospital. Cognition, 50% of patients, even with the mild ICH, they end up with like mild cognitive impairment or some sort of cognitive impairment. Emotional aspects, 20 to 25% of patients, they end up with depression in the first year, which is usually not being caught, and that's really sad. When you start asking, you see how the disability from the stroke cost them most of their hobbies and motivation in life. And emotional incontinence, 10 to 20%, usually in patients with basal ganglia hemorrhage, they end up having these like outbursts of laughing or crying all of a sudden, or getting very emotional. Those patients actually respond well to SSRI because it's the dysregulation of the serotonin in the basal ganglia area. And the last one is post-stroke fatigue, which is 60% is profoundly disabling to the patients. So there was this concern in the past that SSRIs is going to cause the platelets dysfunction and may cause ICH expansion. But there are recent studies that showing actually it helps sometimes with the motor recovery. There was this study, it's called FLAME. They looked at the fluoxetine and motor recovery. They saw some benefit, and actually they were looking at customize it to each patient. But after that, there were 2 studies, Focus and Affinity. A trial didn't show the same result. In my opinion, it's more indirectly affecting the motor recovery because treating the depression and making the patient more engaged in therapy, it helps with their recovery afterward. So post-stroke fatigue, it's very disabling, as I mentioned. Unfortunately, there is no great treatment for it. There are some strategies that we use. I typically don't treat with medication to start with. Give them 3 months to see how they respond to exercise and try to optimize their sleep. If they have a sleep apnea, screen for a sleep apnea. Do cognitive behavioral therapy if they're having some depression, anxiety. And when check some blood tests, most of people in Wisconsin, they are vitamin D deficient. So check some vitamin deficiency. And especially after a stroke, their appetite gets a little bit lower and they might have vitamin deficiency. And then when all of these fail, I start modafinil. Modafinil has shown some benefit to the post-stroke fatigue, and SSRI indirectly, when they treat the depression and anxiety, automatically it helps with their fatigue. So basically, this is a summary of what we cover in the clinic. Early rehabilitation is very important. PTOT, speech, I always, again, reevaluate them when I see them in clinic. Usually it happens after 3 months to figure out like if they still need PTOT speech or the consult fell through the crack and they didn't end up not getting enough therapy for the problem they are dealing with. Cognitive and emotional support, stroke risk factor management, including hypertension, which is the most important factor in the ICH that we've heard about since this morning. Antithrombotic decision, that's the biggest question that they always ask, when do I get to start my anticoagulation? And life counseling about exercise and limiting alcohol use and et cetera. We will talk about it. So again, I don't know that you had all these amazing guidelines here, but at least I covered the recovery aspects of it, so on your way home, you don't need to cover that part. I already covered it and screenshot everything here. So rehab in a stroke is basically, as we discussed, it's the level 1 evidence that it's starting an early rehab is very important. Early supported rehab is very important. Between 24 to 48 hours is important, but it's harmful if you do it within the first 24 hours. So the AHA guideline, again, about the neurobehavioral, in patients with spontaneous ICH, using the tools for depression, screening depression, anxiety, and cognitive impairment are very important. And the level 2A is referring them to the psychotherapy and helping them with health psychology and treating them with medication for anxiety and depression, it would be beneficial. So blood pressure management, thankfully there is no controversial question about it in the outpatient setting. Long-term goal is 130/80, and we try to keep the blood pressure under that. Doesn't matter what the cause of the hemorrhage was. So yes, that was about the blood pressure. There's not a lot about blood pressure to talk about. That's the number we always go for. About antithrombotic and anticoagulation plan, so, Sue, do you mind just asking them to make the note smaller? The note smaller.
Make this
The note smaller.
note smaller.
I barely can see my slides. Thanks. Excuse me. So about the antithrombotic, basically, as you see, there is no level 1 evidence. It means we don't know. When do we start the anticoagulation, when we start antithrombotic agent. There are some situations that patient has to be on anticoagulation, and in those situations, we resume it. We have no other choices, and those situations are if patient has some devices like LVAD in their heart, or if they are having mechanical valve, they have to be on anticoagulation, or if the patient has a genetic disorder that they need to be on anticoagulation, or if they are hypercoagulable state. So those patients, based on even the AHA guideline, they have to be on anticoagulation. We try to resume it safely. We have the discussion of like risk and benefit, obviously. The rest of it is level 2B evidence. It's all about AFib, and I went forward. I don't know what happened. Here is showing me something else. I don't know. Okay. It's one ahead of me, so it's fine. Just give me a second. They're playing a little bit with the slides. But overall, about the AFib patients, there is no really good answer for, there is no script for all the patients. It has to go based on the each individual, customize it for each individual, and resume it if it's absolutely necessary, and it's a discussion with the patient itself. What I do in my clinic is I try to calculate the HAS-BLED and also the Chagharvand score and put it in front of patient. I'm like, I don't know. These are the numbers. Which one do you pick? Do you want a Chagharvand score of like 8? Or you want a HAS-BLED of like 5, and there is a percentage that comes with it. There is number. It makes it easier for patients. Thank you. It makes it easier for the patients to decide what they want to do. But basically, it's level 2B evidence that you just have to discuss it, or you try to find an alternative plan for it. For example, send them for a left atrium appendage closure in that situation. If you caught the CAA patients early, you can send them for that left atrium appendage closure and be done with the anticoagulation soon, like a little bit earlier in their progression of their disease. So again, the latest trials, they all talk about you can start anticoagulation, but there is risk of, there is always this competing risk of ischemic stroke versus hemorrhagic stroke. Procedures AFib, it was an open label trial. They were looking at 319 patients, and they were patients with prior ICH and AFib, and they randomized patients in 2 groups of starting DOACs versus not starting DOACs. Obviously, the patients on DOAC group, they had a lower risk of a stroke, which was 0.8, but also they had a higher rate of hemorrhagic stroke, which was 5% compared to 0.8 in the group that they were not on DOAC. But the outcome of the study, the mortality rate was the same. That data supports that you can resume anticoagulation, but it has to be definitely a decision between the patient and pulling up the data about like using the tools and make sure patient is aware that there is a risk, and they decide to go with whatever they choose to go. So statin and NSAIDs. Statin, we will talk about it a little bit more, and I think someone else is talking about a statin, so I'm not going to dig into that. Thank you. But in general, based on the guideline, I'm just going to say a little bit small, what I do in the clinic, actually. I'm just going to point on that. If patient was already on it and they have a strong indication for it, I keep them on it and I resume it. And if they have like they have cerebral amyloid angiopathy, I try to stop it just because there are some evidence out there that it might increase risk of hemorrhage. And then NSAID, absolutely no for the intracranial hemorrhage. So lifestyle modification. You would educate patients about exercise, at least 20 minutes a day. Walking would help with their fatigue, would help with their memory, weight loss, hypertension, limiting alcohol, and also if there is any neurocognitive, what is it called? A supervised trainer, and also sending them to counseling would be beneficial to them. But one of the important factors that we always miss is supporting the caregiver, educating the caregiver. It shows that it increases the outcome, it improves the outcome. And also supporting them. Like I usually ask the caregiver if they have enough support at home, if they are able to handle it, if they have transportation, if they have access to the food. And in those situations, it's really important to involve the social worker. And I always try to consult social worker on my patients my patients or the caregiver that are struggling with the disability forms or so many other social aspects of it. So recovery time is it's a nonlinear curve in ICH. Like ischemic stroke, the first 3 months is usually very fast and they gain what they gain, but up to a year, usually the cognitive and emotional aspects keep getting better. So it's important to educate the family and be realistic with them, family and the patient, and make sure they are aware that it's not a sprint and it's a marathon. The recovery is not easy. It's a very long process. Excuse me. But some knowledge gap they always ask, and we don't know how to answer that, is driving. When can I go back to driving? I typically send them to occupational therapy and to check for IADLs and see if they're able. And if they even pass that, I still tell them, sit with the family, and if they feel comfortable with you driving with short distances, try that. If they are not comfortable with you, just, okay, fine, you should not drive. And if they're really insisting, which usually happens in the clinic, I send them again for driving tests. Try not to take away their driver license just as an ID, but I will send them for another round of driving. But some of these patients, as you are aware, they can be disinhibited and they would not listen to you, so then there would be actions. And when do they want to go back to work? My approach usually to that, if someone is having a severe cognitive impairment and was a scientist at a hospital or at a research facility, those patients are usually going to struggle with that, and it's better. I try to see them more frequent in the clinic than discharging them faster, and try to give them this news, kind of like bad news slowly, that maybe it's time for retirement or early retirement or disability, because it's a very hard thing to accept that you can go back to work. We still don't know how to deal with the sexual dysfunction in these patients and if the stimulant really help with the fatigue. So this question is always asked, what are the chances that I'm going to have another hemorrhagic stroke? The recurrence rate can vary between the etiology of the stroke, obviously, it's between 1.2 to 7% in undifferentiated group, but when you differentiate it from the hypertension to cerebral amyloid angiopathy, the numbers are going to go up significantly. For example, in cerebral amyloid angiopathy, it would be something around 7.4% per year, which is a high number. And the other thing about the cerebral amyloid angiopathy, it's higher in the first year the recurrence of the ICH, but it never stops. It continues. So that's important for them to know. One, excuse me, subtle way of me asking the patients of CAA is, do you have a healthcare power of attorney? Do you have this? Like somewhat I try to like make them ready for this is a progressive disease. Have you made your decisions about your finances, assign someone to it, even though that's, it goes a little bit beyond, but I deliver that news to them slowly so they are aware that they are supposed to, they would expect it, that someday this big hemorrhage will come. So yeah, that's what I just talked about. So what makes it higher risk for ICH? There are a lot of factors. Older patients, hypertension if it's uncontrolled, if we control it in the clinic, that's great. Antithrombotic agents, those are important. Like if someone is on antithrombotic agent, the risk is higher, obviously. A statin, question mark. I leave it for our next speaker. CAA group, AVM malformation, it's either untreated or like semi-treated. Sickle cell disease, moya, brain tumor, CKD, prior stroke and ICH, actually, it increases the risk of recurrent hemorrhage. And patients with genetic disorder, mostly the apoprotein E2 greater than E4. So the typical concerns we address in the clinic is figuring out what is the etiology of the stroke, why they even had the stroke, hemorrhagic stroke in the first place. There is this nice diagram from UpToDate, actually. So if patient is there with a basal ganglia hemorrhage, thalamic hemorrhage, cerebellar hemorrhage, or brainstem hemorrhage, older than 65, history of hypertension, those are in the category of patients with hypertensive hemorrhage, so you don't need to do further workup really at that point. If they're not in that category, you look at their imaging, and are these patients in the category of cerebral amyloid angiopathy? And if they are in that category, then you don't need further investigation. It's already answered. But then if they're not in the category of cerebral amyloid angiopathy with a bunch of microhemorrhages or superficial siderosis or a lobar hemorrhage, then you want to and if the imaging is suggesting some secondary cause, you want to do more investigation and do MRI, MRV, whatever you think that is the cause of the problem with contrast, because that could be mets to the brain, that could be a venous infarct, or so on. But if the imaging is not showing any secondary cause, you want to repeat the imaging. I typically do it in 3 months. Some guidelines, they say 6 to 8 weeks, but in my experience, every time I repeat it in 8 weeks, there is still blood, and they say they are not able to for sure say that there is nothing under the blood, under the bleeding area, so I usually repeat it after 3 months. So we already mentioned the blood pressure management, that has to be less than 130/80. Anticoagulation and antiplatelets. Some people are high risk, as I already mentioned. Patients that are cancer patients, they are high risk. And for those patients, you can check a D-dimer, see if those patients are are in hypercoagulable state or not. Not all the cancer patients are hypercoag patients. Someone with mechanical valve, they have to be on warfarin. You can't avoid that. And other hypercoagulable conditions like factor V Leiden and like antithrombin 3 like deficiency and so on, and patients with PE, for example, or a DVT or recurrent of those issues, or venous sinus thrombosis, they have to be on anticoagulation. Actually, in hemorrhagic venous infarct and with hemorrhagic, even though they do have blood in their brain, we still continue the heparin and we still continue treating them with anticoagulation. If there's a thrombus in the heart, you definitely want to continue anticoagulation, or you're going to end up with a thrombectomy case. And if they have to be, if they have some temporary high risk of anticoagulation, for example, if someone comes in with MI and they have cerebral amyloid angiopathy, you have to continue that. And it's the same thing as that I just mentioned. So if they have to be on one of those, you resume it. If they don't have any of those absolute indications, and they have AFib, you want to resume it again or discuss it with the patient. And if they are not in that category, you resume it. Sorry, if they have AFib, you have to go through the path of like, is this cerebral amyloid angiopathy? Yes, it is. You discuss it with the patient. You send them to cardiology for closure, for left atrial appendix closure. Try to find other alternative ways of not giving them anticoagulation. So after etiology is resuming statin, I will skip that part because you will hear better from our expert. And this was a Sparkle trial, probably it's in your slides as well, so I'm gonna skip that one too. But what I really do in the real world, so this was all the studies and guidelines and this and that, but this is my clinic note template. This is actually what I go based on because I don't wanna miss anything. Patient starts talking, I start talking, I'm chatty, they're chatty, so things get missed. I ask about their headaches, usually it's patient brings it up. Usually if they are having headaches and subarachnoid hemorrhage patients especially. Cognition, for the headache, what I do is if they especially had craniotomy, you want to know what type of headache they have. If my favorite medications, if they had a craniotomy and they have like paresthesia and like pain, neuropathic pain from the surgery, gabapentin is usually a good medication, Lyrica is a good medication. If they had headache due to subarachnoid hemorrhage, you want to give them something that is like vasoconstrictive. Like I typically pick verapamil. It's easy. It drops their blood pressure a little bit, which is one of our goals in hemorrhagic patients. For the cognition, I typically check blood work and make sure they're not deficient in any source of vitamins, B12, B1, B6, vitamin D, a TSH. It doesn't hurt to check a CBC and a CMP. And then if those are normal or I fix them or replace them, I try to send them to a neuropsych testing to have a baseline of their cognition, cognitive impairment, and speech therapy referral to work with them and teach them some strategies to help with their memory. For the mood, I'm comfortable. We are psychiatric and like neurology, like board certified, but really I'm comfortable with 2 medication. After that, I pass them to the psychiatry team. Usually the SSRIs are easy medications to start them on, but then make sure you connect them with the health psychology as well. Fatigue, as we discussed, exercise first, checking the vitamins first. Modafinil is the other option that I go with. I definitely screen them for sleep apnea. It helps with the blood pressure, with their memory, with recurrent stroke. So it's a good thing to screen, and that's a mandatory dot phrase that I have to use to let those patients in the stroke clinic, in the sleep clinic. So I use that for the sleep apnea screening. We do have an amazing group, thanks to Melanie. This group, actually, patients are really, really loving it, and they can, I think, connect throughout the whole Wisconsin, yes, right? Yeah, anywhere. So they can, this is a support group for stroke patients and aneurysm patients. No matter how much you talk to these patients and try to give them reassurance that this happens to other people, you are not alone, no one understands them in their families, so they enjoy it, they love it to be surrounded by a group of people that they went through the same thing. I always refer them to this group. They can even join online if they have transportation issue, or just meet people in person, and they end up like being friends. And I always hear good feedback from them. So post-stroke care is definitely a multidisciplinary and deeply personal care, and you want to make sure you work with other team, including our rehab patients, our rehab team. I usually refer them for Botox injection if the baclofen and tizanidine and all those like medications with their side effects is not working. You want to make sure you talk to the neuropsychiatry team. for their cognition. You want to work with your psychiatry team for their mood disorder. So it's really a multidisciplinary and interdisciplinary care to take care of these patients. Any questions?
If you have questions for Dr. Seppi, please head to the microphones.
Hi. I have a question, and I wish I could have heard your talk 6 years ago when I started seeing stroke patients in the clinic. But in the guidelines, it says no non-steroidal anti-inflammatory drugs for long-term use, but do you have a recommendation for short-term use? Like, is it an absolute no for those, or can these patients safely take an NSAID after an ICH at some point?
So based on the guideline, it's harmful. But I always no matter what I say to my patients, they're going to cheat. At least you can just educate them. I always educate them that you are going to increase your risk of hemorrhage. But if you are absolutely in so much pain and Tylenol is not doing it and using the cream and lotion is not doing it, like having once in a while cheating and say or naproxen, that again, that would be that individualizing the care and not really being very strict with the guideline. If patient is suffering from that pain and is making them disabled more than the actual intracerebral hemorrhage, so it's okay to just have it once in a while.
Okay, thank you.
Sure.
Our stroke program has had a bit of an issue getting the 90-day modified Rankin score within the parameters. How does your stroke program deal with that?
That is a great question. So actually we are one of the, I think, 6 or 7 programs that we've started doing that, and we've done it for 10 months. And I wanted to present the data, but we didn't have enough information to present it. We just contact the patients, and actually Melanie can maybe speak better to that. But we contact the patients and go through the questions with them.
Just like via call?
Yeah, via
Okay.
phone call, yes,
Oh,
exactly.
perfect.
Is
Thank
that
you.
correct, accurate? You can speak to that if you want to.
Hello, thank you. Yes, we utilize the Get With the Guidelines 90-day MRI, 90-day stroke form, and I download that every, how often do I do that? Pretty much every quarter, and after discharges come through. And I complete the phone calls myself. I'm the stroke program manager. Do those follow-up calls. Most of the time I am reaching those patients. I would say I have a pretty high percentage of reaching those patients. And to add to what Dr. Chagharvand was saying, the phone calls that when we do connect with them, they do appreciate that continuity of care in the clinic, and just having another voice to talk to after they've left their hospitalization. So I think it's definitely been impactful for me on the receiving end of that to be able to make those connections with those patients. Thanks.
Thank you. Great.
Anyone else? Thank you so much. We appreciate you.